Thank you, madam. And at the outset, I thank Dr. Kumar sir and his team for consecutively calling me to this receptor. I'm happy to see the hall almost full on this Saturday morning. And I'll be talking on premature ovarian failure. And though it looks like a gynecology topic, it actually is common, not like uncommon what we are actually would have taught before. And it's common to general practitioners, physicians, not alone to the gynecologist. Many of them are undiagnosed, many of them are not getting treated. I think that's why Dr. Kumar has put this topic on this morning. And my focus will be on early diagnosis and fertility preservation. That will be the focus of my topic. And a lot of things have happened in the past 2 to 3 years that had actually changed the way it's defined and the way it's diagnosed and the way it's managed. So I'll be focusing on all those things. So before going to topic proper, the terminology premature ovarian failure is not actual because it's not, when we say the word failure, it means the end of everything. But actually not so, because a significant percentage of people with premature ovarian failure do revert, and that's why the terminology now has been changed to premature ovarian insufficiency. And European Society of European Society of Human Reproduction and Embryology has in 2024 gave a new definition for premature ovarian insufficiency. Any woman less than 40 years with oligoamenorrhea and with an FSH more than 25 has to be called as POI. Initially, the FSH level used to be more than 40. As a result of that, we diagnose many people who are in the last, that is complete POI. Because the focus is on early diagnosis and fertility preservation, the diagnosis has to be changed. That's why ESHRE in 2024 brought down the FSH level from above 40 to above 25. As a result of that, two new terminologies have started emerged. One is biochemical POI, where there is AMH which is low. The patient can be menstruating regularly, but the antral follicular count will be less than 5. So this is a window of opportunity for fertility preservation. The second level is overt POI, where patient will have oligomenorrhea and the FSH will be more than 25 and patient will have some amount of detectable AMH. The complete POI is when AMH is undetectable and the patient has gone for a permanent cessation of our menstrual cycle. So these two new entities, that is biochemical POI and a complete POI, has come into the definition in the last 2 to 3 years. So let's look at the epidemiology. This is the pivotal study. This meta-analysis had included around 280,000 patients. And when they studied, the global prevalence of POI is 3.5%. Initially, it was considered as 1.1%. The prevalence increases as the age increases. At the age of 20, the prevalence is 1 in 10,000. At the age of 30, the prevalence is 1 in 1,000. At the age of 40, the prevalence is 1 in 100. Right? And the commonest cause is idiopathic. Around 60 to 70% causes are unknown. And around 11% in this particular meta-analysis is due to idiopathic cause. Trauma to the ovary or injury or any radiation, chemotherapy or infection led to idiopathic POI. Around 10 to 12% are due to autoimmune causes. Regarding the prevalence in our country, the National Family Health Survey Study 4 puts the prevalence as 2.2%. So we have lesser prevalence of POI compared to the global prevalence. And the highest prevalence was seen in the state of Telangana, 14.5, due to unknown reasons. And I couldn't find any reason why this prevalence is high in Telangana. And the common reason what they found was low socioeconomic status, lower education rate, yearly menarche, high parity, living in rural area, smoking and tobacco use, all are reason for POI in our country. And let's move on to the diagnosis. So initially, as I told you, AMH was not there. Now the diagnosis by as of 2024 is a single value of FSH more than 25 in a woman less than 40 years of age with low AMH and antral follicular count less than 5. This fits into the diagnosis of POI, and the recent definition also includes the role of AMH, genetic testing, and also muscle health has been brought into the diagnosis. We'll see it in the further slides. And AMH, as you know, it's commonly used, easily available. Having said that, the quality of AMH tests in many of the assays are questionable. So one must be aware that the AMH is also being done in card method where the reliability is less. The normal AMH in a woman is more than 1. Whenever the AMH is between 0.1 and 1, it's considered as biochemical POI. Complete POI when the AMH is less than 1. And the undetectable means complete POI. And any AMH less than 0.5 should trigger an investigation for a possible POI in future. And one must also do FSH and also antral follicular count. Regarding the antral follicular count, it's done with a transvaginal ultrasound probe, and a value less than 5 is considered as abnormal. We should take into account both the ovaries for the antral follicular count, and it also measures the ovarian volume. Any ovarian volume less than 3 is considered as a high risk factor for developing POI. Anybody with a antral follicular count less than 5 and a AMH less than 0.1, one should also go for karyotyping and further investigation to look for the cause so that preservation can be done for this patient and prognosis also can be done. And this is how one should proceed. First, any clinical suspicion is present, do a hormonal evaluation, a FSH more than 25 and the estradiol level less than 50 should make us suspect. Do a pelvic ultrasound, look for the ovarian volume and also the antral follicular count. And in people less than 30 years of age, do a karyotyping. And there are many genetic analyses that are available now. To mention it, FMR1, it's a familial mental retardation 1 gene pre-mutation, which is very common in them. Also do an autoimmune screen. Many people have got anti-TPO positive, anti-thyroglobulin positive. They also have got antibodies to steroid enzymes, 21-hydroxylase, 17-alpha-hydroxylase. So those should also be done when there is associated autoimmune disorders and other clinical features that suggested. With the availability of next generation genome sequencing, a lot of genetic panel are available commercially. You can order for those panel and it costs just 18 to 20,000 rupees and you can diagnose many of the underlying genetic abnormality in these patients. Coming on to the genetic defect, initially genetic causes was attributed to 11%. Now it has increased to 41% thanks to the NGS sequencing and also whole genome exome sequencing, which is commonly being applied to all these patients. So the yield is in 41% now, what has been 11% before. And X-linked disorders are more common in them. One thing to mention is familial mental retardation 1. The Fragile X syndrome we would have heard about. Many of the family members in the Fragile X syndrome have got neurological and psychological disorders, autism, and varied presentations of a lot of psychological issues that runs in this family. These family members have got a high risk for premature ovarian insufficiency, and what is typically seen is the CGG repeat. If the repeat is more than 50, then the risk for POI is high. And this is the commonest test done. We can alone test for FMR gene mutation, not as a whole gene panel. And genes which are involved in oocyte differentiation, oocyte adhesion are also associated with POI. And when we come into the autosomal gene variant, one thing to mention is the NR5A gene. They have associated adrenal insufficiency. That's why any person with Addison's disease, they have a high risk for POI, and this gene has been proposed as one of the important cause. And another thing to mention is the MC8 and MC9. They have a high risk for malignancy, and this they have to be, if this gene is detected, then malignancy screening has to be done regularly. So this particular study, which was published in Natural Medicine, they included around 1,000 patients. They did a genetic analysis and they found 23.5% of people had a attributable genetic risk, and around 20 gene markers have been found in these patients. Moving on to autoimmune disorders associated with POI, and a lot of immunological changes happens in the ovary. They have lymphocytic oophorytis. Selective destruction of the antral follicles happen in patients with various rheumatological disorders. In patients with polyglandular autoimmune syndrome and patients with Addison's disease, the odds ratio to develop premature ovarian insufficiency is to the tune of 22. Even patients with autoimmune thyroid disorders, patient with type 1 diabetes, patient with celiac disease and SLE are at high risk for developing premature ovarian insufficiency. So have a high index of suspicion when people complain of irregular cycles. Keep also this entity in mind. And one thing to be mentioned is any patient with autoimmune POI, the treatment of choice is glucocorticoids. Having said that, this recent publication, usage of monoclonal anti-CD20 rituximab in patients with POI found that around 5 out of 7 people when given rituximab, they improved. They had spontaneous menstrual cycle and the ovum retrieval was also high in them. So this opens up a new gateway for immunological intervention in patients with autoimmune disease related POI. Having said that, this rituximab can exacerbate the adrenal crisis, so they should be managed properly, and it's just an experimental study. It's not a recommendation to use in such patients. Coming on to the guidelines, the first line of therapy is the hormone replacement therapy. Having said that, HRT, when we say it's not equivalent to the postmenopausal HRT, what we usually talk about. Because HRT in a menopause is different from HRT in a woman with POI. The dose of estrogen is high in patients with POI with HRT. In postmenopausal status, HRT is optional, whereas in premature ovarian insufficiency, the HRT is mandatory and essential. And even with so much of awareness, around 30 to 50% of the people do not receive HRT with POI. Once we use HRT, there is a 80% resolution of the hot flushes what they undergo, and they have an added life expectancy of around 2 years. And regarding the duration of HRT, it's 51 years. That's the ESHRE new recommendations. And dose of estrogen is high, and combined oral contraceptive pill should not be used in this patient. I'll tell the reason why. And these are the various ways you can replace the hormone replacement therapy. The best method is transdermal estrogen patch. And we have to give progesterone in the form of micronized progesterone for 12 days in a cycle to cause withdrawal bleed. But the availability of the transdermal estrogen patch is limited, and what we usually use is estrogen valerate, 2 to 4 milligram daily. And again, combined oral contraceptive pill, the dose of estrogen is less, and it is not physiological, and it should not be used in these patients. The woman with POI, even if you start HRT, they are at lot of other medical complications, the cardiac and also the lipid, psychological and bone health issues happens. And this slide tells that even with HRT, the incidence of CV events is 1.3 times higher in patients who have POI. The MI rate increases by 1.4 times and the stroke risk increases by 1.2 times. And these events occurs 2 years earlier in these patients. So what happens whenever a lady has a POI? There is increase in LDL, there is reduction in HDL, there is sympathetic overactivity, and endothelial dysfunction starts, and all the inflammatory markers starts raising. And though we use HRT, it cannot be normalized, it is minimized. That should be kept in mind. And moving on to bone health, which is very essential in these patients. These patients have got a lifetime risk of 2 times higher risk for developing major osteoporotic fractures. And within 2 years of POI, they have more than 30% reduction in the bone mineral density. A DEXA scan should be done at the time of confirmation of the diagnosis, and every 2 years it has to be repeated. All of them should be on calcium and vitamin D. And for osteoporosis, bisphosphonates are not a treatment of choice. It's only for the postmenopausal osteoporosis. In a patient with POI, it has to be HRT. Properly administering HRT treats osteoporosis better than a bisphosphonate. So this should be kept in mind, and bone markers also can be done to monitor the therapy. And they are also at high risk for mood disorders and cognitive dysfunction. And people have done MRI study in people with POI, and they found that the gray matter in the hippocampus, the frontal and parietal cortex have in fact shrunk, just like what an Alzheimer's disease has. Basically, estrogen has got a neuroprotective role. It improves the synaptic plasticity and prevents amyloid deposition in the brain. In patients with POI, they are at increased risk for dementia, increased risk for Alzheimer's, and also Parkinsonism. And treating them with HRT improves many of the cognitive dysfunction in these patients. And another thing is sarcopenia. The ESHRE includes sarcopenia in the definition. Estrogen improves muscle protein synthesis. It also stimulates the satellite cells in the muscle fiber. It improves the grip strength, it increases the gait speed, and it also increases the muscle bulk. So so people with POI, sarcopenia is another threat which predisposes them to fracture and also causes an yearly frailty, and this also should be monitored in this patient. And moving on to fertility preservation, the last part of my presentation, and spontaneous fertility is seen in these people. Even though we say POI, if you take a ovarian biopsy, 1/3 of them will have preserved follicles. Around 29% of them spontaneously ovulate and resume cycles. That's why the POF is replaced by POI. Around 5 to 10% of them do and conceive naturally. That's why anybody who give the diagnosis, do not give them a grave thing telling that everything is over, you won't get pregnant, because we have to wait for 1 to 2 years to see that this spontaneous ovulation happens or not. Meanwhile, you also arrange for womb donation and other things and wait. And one misconception is if you give HRT, like what we do in testosterone, if you give to male, the spermatogenesis is suppressed. But similar thing doesn't happen in a woman. If you give a HRT, the follicular development is not retarded. So one should not think that if I am giving HRT, spontaneous ovulation doesn't occur, or the follicular development will get halted. That need not be worried. It should be proceeded, and the other treatment has to be continued. Okay, and the standard of care now is oocyte retrieval and cryopreservation, which has got a success rate of 85% and pregnancy rate of 68%. I think all the centers do this oocyte. Depending upon the AMH level, they do the stimulation with the gonadotropin and then do it. So any patient with a genetic mutation like FMR1 mutation, anybody undergoing chemotherapy, radiotherapy, and they should be, or bone marrow transplant, they should have their oocyte retrieved, cryopreserved, and they should do that. And role of GnRH analog also are well appreciated in these scenarios. And another thing is ovarian tissue. They do a wedge biopsy of the ovary, they cryopreserve it, and once the procedure is over, they re-implant in the peritoneum. The advantage is that the endocrine function of the ovary is sustained. Having said that, not many procedures have been done globally. Over 200 pregnancies have been reported, but the experience is limited in this way of fertility preservation. And people also now talk about in vitro activation. What they do is they do hippo signaling. They take out the ovarian sample, they do vibration, and they do the follicles develop. This is called as in vitro activation. They also give AKT activators to improve the folliculogenesis, and all have been in the trials. Moving on to the novel and emerging therapies, and finerenone. Don't think that I have put some wrong slide. Finerenone is a drug being increasingly used by the physicians, endocrinologists, and nephrologists for reducing the CV events in patients with diabetes and CKD, and also in patients with CKD, right? And what role it has in patient with POI? See, whenever there is a premature ovarian insufficiency, it's not only the antral follicle which is involved, but also the stroma. Mineralocorticoid receptors are expressed in the stroma around the follicles. Whenever a patient has POI, there is fibrosis around the follicles, which prevents the follicular development. And this particular drug, finerenone, which is a non-steroidal mineralocorticoid receptor antagonist, it reduces fibrosis around the follicle. In this pilot study, when they used it in patients, around 1,297 patients, there were around 14 patients who responded with spontaneous follicle development. They didn't give it as a daily dose. They gave twice weekly. So this is encouraging. So there is the other ways by which we can target follicular development, and I think this should be taken up as a bigger study, and many facts will emerge after this. And there are many quark-like practices which has been done, but they have shown also results like PRP, injection into the ovaries. Not approved method, but what people have documented is it gives growth factor and improves the follicle rate, and around 8% pregnancy rate has been seen with this type of thing. And again, for your information, but please do not do this. And the other things in the pipeline, novel therapies are stem cell therapy, mesenchymal derived stem cell therapy, which give growth factors. So injection of mesenchymal stem cells into the ovaries have been studied and found to be beneficial. And people also use exomes, mesenchymal stem cell derived exomes, to treat POI. So what you need basically is a multidisciplinary team. Just diagnosing doesn't thing. One way saying endocrinologists or gynecologists cannot do all the things which were discussed. So what we need is an teamwork which includes a gynecologist, a endocrinologist, and also a psychiatrist, and also an embryologist, and also a rheumatologist or a osteoporosis management, and also cardiologist. So they belong to the whole team, multidisciplinary team, to manage these patients. So the onus lies on them to suspect the diagnosis and establish the diagnosis, evaluate them, and do not give them poor prognosis. The best way to treat this patient is ovum donation. Tell them. So that's an easier way of getting it done, which has got a higher pregnancy rate. And in people who are willing for their own oocyte to be retrieved, then adequate referral to the gynecologist or a fertility specialist should be done. In the long term, as physicians, we should monitor their bone health, their cardiac health, and also their mental health. So I would like to conclude by saying, diagnose this patient early, investigate them thoroughly, and HRT is essential, not optional, and the fertility is not zero, 5 to 10% they conceive by themselves, and finerenone role is encouraging, and multidisciplinary care is mandatory for these patients. Thank you.